So, this is the talk given in Thrissur on March 15th, and it was this conference of surgeons and plastic surgeons and orthopedic surgeons. And basically, it's talking about rehabilitation after common peroneal nerve repair. I think the first thing to do is explain what reality is. And standard rehab is not just some protocol or a guideline that can be followed. Standard rehab is customized to the patient. So because everybody is unique, plans will be complex. Hence, for the sake of this talk, we're going to talk about a very simplified patient. There's only the peroneal nerve damage. There's damage in the leg segment only. There's no concomitant neoplasm, hypomyelination, polyneuropathy, canal stenosis, radiculopathy, or spasticity. There's no sarcopenia. There's no obesity. The flow in the blood vessels is triphasic, meaning it's very good. And there's no compartment fibrosis. That said, we have to look at the domains that rehabilitation covers because we're talking about a nerve injury. This is actually much more than just the nerve. So the total functional length of the nerve is about 35 to 45 centimeters, meaning it's going to take 350 to 450 days to get to the distal neuromuscular junction, depending on where the nerve injury happens. That said, the nerve will take that much time to recover. It could take about a year. That's not the only thing affected though, because the nerve actually supplies muscles. So we have a neuromuscular domain that we have to consider. And the changes in that will begin after the nerve is injured, but they can take longer to heal, so 3 to 15 months. There's also a rheological domain where the muscles themselves are undergoing changes related to the damage and the rehabilitation that can go from 6 to 18 months. And then from there, the emphasis, the thing that's most overlooked, which can be lifelong. So we're going to look at all these different domains in detail as we talk about rehabilitation. The first thing is nerve. So when we look at the nerve and its damage, we can stratify its severity by electrophysiology, nerve conduction studies. And that will give us a neuropraxia, which can go straight to rehabilitation, an accident or neuromesis, which may require some kind of surgical intervention. And after surgical intervention, they can get rehabilitation. So what is that rehabilitation? So the first thing is these nerve damages usually affect the gait cycle. And how? Well, in the mid-swing phase, you can have ankle dorsiflexion not working. In early stance, you can have a problem with controlled lowering of the foot after heel strike. In mid-stance, they can have problems with lateral foot stability. And in the last, sometimes the nerve just works, but the brain doesn't know. So it's disuse apraxia. Sorting that out is part of our work. Now, what do you do for that? I think the key to understanding is that the muscle doesn't just move because of the nerve, it moves because of the brain. That said, mental imagery and motor retraining can be very helpful in getting that muscle to work again. The next thing is gait training focus on restoring normal mechanics. The next thing is, in the worst cases, definitely mobilize to walk as soon as possible. And some cases, they come to us with nerve damage, the amplitudes and the axons are low, so they don't qualify for a nerve surgery, but their amplitudes are still low and the muscle is not working that well. Now, for some of these cases, what we do is an ultrasound-guided perineural PRP injection to get that nerve to improve. Some people come with a nerve conduction that looks near normal. So it's not perfect, or it might be perfect, but the nerve and the muscle, they're just not working. What we find is if you do an ultrasound-guided hydrodissection of the nerve, then these things can actually improve quite well. That's the neuromuscular domain. Let's talk about the biological domain. So this is the muscle, and the muscle changes. Basically, we're left with a deafferentated muscle that has partial reinnervation or synkinesis. The goal here, especially in the worst cases, axonal neuromesis, is to preserve the neuromuscular junction. And we can do that with the galvanic stimulation, high amplitude interrupted electrical current can definitely make the muscles twitch, and that would preserve the NMJ on some level. The problem is the muscle is not just one type of fiber, it's multiple types of fibers, and galvanic stimulation selectively targets type 2 twitch fibers and makes those hypertrophy. So in that time frame of doing stimulation, if a person is not gaining, if they're not gaining control over their muscle, by the time you stop, the effects will fade within 2 weeks. And this is a very particular type of patient who gets better but then gets worse. So it's important to realize these things have a value, but they're not cure for it. That said, we're left with a weak muscle. If the muscle is totally flaccid, to prevent contractures, but sometimes, and actually most of the time, we're left with retraining a muscle that just doesn't work. So the muscle has some power, but it's not doing its job to the best of its capacity or the way it should. What do you do with such muscles? Well, preventing contractures passive range of movement, but if they have some movement, active assisted movement, active range of movement are all useful. If they can go against resistance, progressive resistance exercise is very useful. But sometimes they don't even do that while you're waiting for the nerve to touch down in the neuromuscular junction after a repair. The thing is, no muscle in the body works alone, it works in tandem with other muscles. And we know that there's things called myofascial chains where muscles work together to produce functional activities. So sternocleidomastoid, rectus abdominis, quadriceps, tibialis anterior, extensor hallucis longus, all from the superficial front line, and these muscles all work together to produce functional movements. The deep front line, so it's measured at the longest tibialis anterior, the spiral line, gluteus maximus, biceps femoris, peroneus longus, tibialis anterior. Now, all these muscles, they work together to produce functional tasks, meaning the brain knows that muscles that fire together wire together. So even if you're missing one muscle in the chain, you can get the same chain to activate by doing functional tasks. And the easiest of those is the squat. What we're left with clinically is a person who has stance and early swing ankle instability. There's a time where the nerves will slowly be reaching down and growing and improving. And in that time frame, you need some kind of support. So if the person is just having fatigue and instability where they can walk, they get ankle dorsiflexion, they get a heel strike and controlled lowering. If fatigue and instability is the only problem, you can go with an ankle minder. It's really good. It controls the things and lets the muscles work. Most people are left with weak muscles or a subtalar joint that's unstable, in which case what they need is a stronger AFO. Now, a posterior leaf spring AFO works well if you have some degree of subtalar joint stability. The carbon fiber AFO works if the subtalar joint is stable, but you just want an energy release and a push off. An articulated AFO is good for really weak and unstable subtalar joints that have some power. This allows normal mechanics to happen. Of course, most people that require nerve surgery will have a flaccid ankle for a good amount of time, and a solid AFO works quite well at that. Now, the emphasis is the last domain. This is frequently overlooked by everybody. It's what takes the brunt of all the abuse from the injury and the rehabilitation. And most people have no idea how to address this. But again, what we see is a muscle that's working the way it should, but it fatigues early, it hurts with fatigue, there's trigger points, there's ankle pain. What we do for these patients is prolotherapy or even isometric exercises. The question people frequently ask is, what can a therapist do versus what can a family do? Eventually, you're going to get a patient who can't just throw around money to get high quality therapy. The key here is understanding that quantity is not quality. So short, frequent sessions throughout the day are definitely better than one long session. And we say this because the tendon fatigues at 30 minutes. So if you're going to have a 1 hour therapy session, it's convenient for the therapist to come and do and go, and it's a standard billing code, but the body is fatiguing. And if you push it more than 30 minutes, you're going to start damaging other structures. So this becomes a problem. The other common reason to get a therapist involved in electric stimulation, these machines cost about 15,000 rupees, but a trained family member can do it multiple times a day versus 1,000 rupees per session by a therapist. Does everybody require to buy their own machine? No, of course not. It's really best when you have a nerve repair, and it's going to take time to get that neuromuscular junction preserved so the nerve can reach it. So these are kind of cases, the more complicated ones, they're better off getting their own machine and learning how to do things on their own. Of course, electric stimulation can burn the tissue, but they can be taught about these things. Why would you need a physiatrist, the kind of doctor that I am? It seems like it's just mostly a surgeon and therapist issue, or maybe just the family doing stuff. But many patients, they're not sure when therapy ends. If they're happy with their outcomes, they stop coming, and that's great. But they're not sure they can get better or not. So that's something we offer. Orthotics, as you've seen, we take care of. Nerve and plexus procedures are things that we do. You've seen them. Emphasis issues like prolotherapy, electrophysiology for stratifying the severity of the problem. And then the real question is, if a person comes with a peroneal nerve injury, are they where they should be or as expected, or is there something that's missing? And if why is it not better? That's the question we have to answer. That's what we do for people like this. That's all.